starting with the acute pulpitis. So very important. Acute pulpitis we have discussed before, this reversible, irreversible. Now moving to the severity, which was in the classification, it was acute and chronic. First we'll discuss about the acute. So how the you will consider clinically that the patient is of acute pulpitis patient. The patient will have throbbing pain, yes, severe throbbing pain. Next, it will be either lacinating in type or either precipitated by cold stimuli or laying down. Three stimuli, and the due to which the patient is will be awake throughout the night. Okay, so there's basically either the stimulus is hot, cold, or laying down. The pain lasted for 10 to 15 minutes, more or less. Okay, you can see that this is an abscess of the pulpal horn that is in young, very important. Either it will overheating which occurs during any preparation, either you went for the endodontic treatment for the filling, either the blood vessels are ruptured that have formed hemorrhage or hematoma. The next will be, if you want to say that this pulpitis should be acute, so no possibility, you will not drain out that exudate. That exudate will remain in the pulpal tissue and will build up the pressure and involve the entire pulp. Mostly it is in younger or with the wide dentinal tubules patient that have. Okay, acute pulpitis are basically either focal. Acute pulpitis means it is only confined to the horn of the pulp. Okay, either it involves the entire, means then it is total acute pulpitis. Means of course this is an inflammation. So you have polymorphonuclear leukocytes. It consists of, it has fibrin necrotic tissue in the background and extra vesicated RBCs. It contains the granulation tissue which is may or may not present. Granulation tissue is basically when the connective tissue is newly formed, so it is considered a granulation tissue. The main difference between the granulation tissue and the connective tissue is that the presence of collagen fibers, the blood vessels, and fibroblasts. So basically the collagen fibers are less in granulation tissue and more in connective tissue. Okay, and in granulation tissue the fibroblast and blood vessels are more as compared to connective tissue. Moving towards that, this is an acute pulpitis with the intraoral abscess. You will have to, they have reacts to low level of currents, no change, the X-ray is normal. Either remove the pulp, palpotomy, or RCT is done basically. Chronic pulpitis patient clinically comes with a very spontaneous attacks of dull itching pain that lasts more than 1 year. There is in abscess of system, if the abscess is present, it is not the evidence that the pulp is normal. Your pulp is dead and the patient has no previous history of the pain. Okay, basic clinical decision which has to be made. Okay, so basically reversible and irreversible, which is clinically is determined basically the management of the effective tooth. When you will manage that effective tooth, so basically it clinically that is okay. Now moving towards another is, there is no penetration of the bacteria in the pulp. No penetration of the into the pulp by the bacteria, and this is basically in the old people. That acute was in young people, because in older people there are restorations, there is slow progressive caries due to narrow and they have narrow dental tubules. In acute you need a wide dental tubules. You can see a large carious region in older patient, and as a pulpal tissue contains a diffuse infiltrate of inflammatory cells. Now histopathology, they have delicate dense connective tissue, in that there was a granulation tissue. Okay, a bundle of dense collagen fibers you have. There is a decreased number of blood vessels due to inflammation. There is lymphocytes and blood vessels. Okay, then you have the pulpal fibrosis is present. If it was not treated on time, there will be a pulp stones, we will discuss in the upcoming, and linear classification it will. Now the you can see macroscopic appearance of pulp with the pulp stones and dystrophic calcification. Reduced response in there was a low response, no change again, and you have to do RCT mainly. Then moving towards one of the most important topic is the chronic hyperplastic pulpitis. It is basically a hyperplastic response of the pulp, means the pulp is increasing, the pulp cells are increasing. Why? Basically because there is a production of the exuberant granulation tissue again. But why? It is basically when the carious region, extensive large cavity is exposed of a young pulp, means when there is a large cavity and the young pulp is exposed to it for a very prolonged period of time. Okay, very important this is. Okay, you can see a molar. Okay, one very important thing that in this the deciduous tooth are involved. Basically deciduous molars are in and the permanent first molar only is involved, so the patient will come in this age. Okay, so this is the molar of young of young of a young patient that there the pulp is inflamed and that has proliferated throughout because there is an open caries defect progeniting in the oral cavity. Basically the cause is also there, slowly the pulp is exposing. There are the main cause is basically the slow progression exposure of the pulp. The next we have a very large cavity, the resistant pulp, apex, wide apex, and low grade stimulus and mechanical stimuli, either it is chewing or bacterial invasion. Now why we need these is very important. Let's study forward. Clinical features: deciduous molar again and first permanent molar. So if there is a white pulpitis, if there is a wide cavity, it will do not put pressure on the tooth. The tissue will not pressurize the tooth. First of all, if there is a wide apex, so there will be more blood supply, there will be more pulpal defense system and repair, so the pulp will be becoming enlarged. Second, basically the granulation tissue, you have a plastic granulation tissue that comes out of the boundaries of the pulp chamber in the form. Basically it has no symptoms until the patient is not doing any chewing or mastication, when the teeth are not in the functional state. It has epithelialized and ulcerated. The epithelialized do not have any it is pinkish white and does not bleed readily. Okay, but accelerated, it is not covered by epithelium, so it becomes ulcerated and of course bleeding. Red in color and bleeds when the doctors of course when probe it bleeds. You can see it, it's very clear here. Histopathology is basically that the entire the inflamed granulation tissue has basically cover, or it has filled the entire space of the pulp chamber. Okay, surface is may or may not be covered by squamous epithelium. That epithelium has migrated from the adjacent gingiva. There is an inflammation tree of the chronic inflammatory cells. Very important that the basically it has 3 points, that the granulation tissue has taken up the whole pulp chamber. Number one. Second, the stratified squamous epithelium may or may not be present, and that epithelium has actually come from the gingiva. And there is of course chronic inflammatory cells. You have you have lymphocytes, neutrophils, macrophages, etc. in this treatment. Either removed it, yeah, endodontically, if you can see of the tooth. Progression of pulpitis, how it actually progress. Basically, number one, it also depend on the nature, severity, and duration. The basically stimuli, that which type of stimuli, how severe, and how for how much time. Then there is also the host defense system. Also, host defense, the efficiency of host defense system, the modifying factors that cause pulpitis. Okay, the rate of progression, also immunological response of the subodontoblastic zone that occur in early stage immunology. Then the formation of the acute oxidate changes that occur when there is more irritation. Okay, and when there is more inflammatory exudate, so it comprises the vascular tissue. Okay, so due to which there is also more inflammation, and more also that if there is ischemia, it can cause pulp abscess. Okay, so these are various factors that progress to pulpitis. Very important, very important sequel of pulpitis. It can be asked in your viva, in your papers, that what is, because it also has importance in periodontitis. Okay, basically what we have is we have so if we have a tooth, okay, if we have a tooth, okay, number one, if the patient have a if the patient has basically acute pulpitis is by any reason, like carious region, anything, so first here uh, it will affect the periapical pedial fibers, and when it will affect the periapical pedial fibers, so it will form the, so what it will form, periapical periodontitis. That periapical periodontitis in what will form, periapical abscess, there will be abscess formation start. That abscess will move to the bone tissue and form osteomyelitis, and then it will move to the periosteum, that is the layer of the bone tissue, and cause periodontitis and will lead to the cellulitis. This is the chart which I have told you, it is for acute. But for periodontitis, what will form, you have periapical granuloma, big granuloma. So if there is a granuloma, the granuloma will move to the periodontal cyst. The cyst will now spread to the bones. It will again form osteomyelitis, then periostitis, and then it will lead to the abscess. So it is very important if it is chronic, sorry, acute and chronic, so it will lead to periapical periodontitis, same. But in acute form it will lead to the abscess, and in chronic it will form the granuloma. If it is then in acute it will form periostitis, in chronic it will form osteomyelitis. In acute it will form periodontitis, in chronic both they will form periodontitis, and then in acute it will form cellulitis. Means if the patient has also cellulitis, swelling, you can consider the patient has been history of pain and etc. In chronic it will form the abscess. Okay, it is one of the most important sequel for pulpitis and periodontitis, also for same, in for cyst. Okay, thank you.